Good afternoon. I am going to present an unusual case of ocular rhinosporidiosis. Rhinosporidiosis is a rare, infectious, chronic granulomatous condition caused by a fish tapeworm. The name is Rhinosporidium severi. It is mainly prevalent in warm tropical climates, and in 90% of the case found in Indian subcontinent like India, Bangladesh, Nepal. In our body, nose and nasopharynx are the most prevalent area, which involved at over 70%. And ocular manifestation accounting only for 15% of cases. The most frequent ocular site is conjunctiva and followed by lacrimal sac. Conjunctival rhinosporidiosis can be of two types, that is flat or pedunculated. A 26 years old male farmer from Keshpur, West Midnapur presented with a pink, fleshy, polypoidal mass from his right upper tarsal conjunctiva since 8 years, which was insidious in onset and gradually increasing in size. We can see there is a pink, fleshy, polypoidal mass hanging from upper tarsal conjunctiva, and yellowish pinhead dot present over it. Excision biopsy shows thick-walled sporangia containing multiple spores inside and lots of inflammatory infiltrates in the matrix, which suggestive of it is a case of rhinosporidiosis. Wide surgical excision of the mass along with cauterization of the base of the lesion has been done, and oral antibiotics along with analgesics given post-operatively. This is the outcome. The first picture shows before excision peak, the right upper tarsal conjunctiva, the mass, overhanging mass, and after excision, the picture. It is presumed to be transmitted by trauma or contact with stagnant water. And Mukherjee P. et al. Reported a case of conjunctival rhinosporidiosis in a 25-year-old male patient, and Thakur SKD et al. Reported a case series of 5 patients. The conjunctiva was involved in 2 patients and lacrimal sac in 3 patients. And patient is now on Dapsone 100 milligram BD dose, which has been prescribed for 3 months. Actually, rhinosporidiosis is an infective condition which rarely affects the eye and adnexa. We live in a hot, humid climate, and there is so much prevalence of nasal rhinosporidiosis. But we can see that only very few case reports in ocular rhinosporidiosis. So we have to be very clinically alert to suspect for preventing the misdiagnosis. Thank you.
So very nicely presented, and a very rare case to develop this. So, but you started, immediately with your biopsy diagnosis. What was your initial differential diagnosis?
Yes, the lead, most common mass is basal cell carcinoma. So, but we have seen that there is a overhanging mass and the yellowish pinhead dot present, and there was a history of pond bathing.
I think your mass was on the conjunctival side, if I am not wrong.
Yes, yes.
So why did you put basal cell carcinoma as your first diagnosis?
Because in the lead, there may be a hanging mass. There may be a case of basal cell carcinoma.
No. See, basically it depends on the tissue of origin. No, the cells. The basal cell carcinoma will not come from conjunctiva like this. It has to be towards the skin side. So, yes, more appropriate diagnosis would be something like a papilloma.
Yes, papilloma, tuberculosis.
Yeah, so those could have been your first diagnosis. And even if you want to put it as a differential, the other thing was that you did excise the tissue. But what I could see was there was a generalized inflammation in the lid, the palpebral conjunctiva. So was everything, just by excision, the remaining conjunctiva could not have been treated. So what did you do for that? If you look back at your photograph,
yes,
one was the overhanging mass and the rest of the conjunctiva looked very unhealthy.
For that, the local antibiotics and oral antibiotics we have given post-operatively.
Okay. Which antibiotic did you give?
We have given post-operatively some tropically we have given moxifloxacin, and orally we have given ciprofloxacin.
Was again the patient immunocompromised? Why did he develop that?
Can you?
Fungal infections again, you don't develop like that. So did you check whether the patient was immunocompromised?
Yes, we have checked. The CBC report was normal, and we have checked the body weight. That was also normal. There is no history of any tuberculosis or any other chronic debilitating condition in case of patient.
Always get a viral markers done in these kind of patients. Okay. Always get viral markers done. Anything you want to add?
What was the status of lacrimal sac in your patient?
Can you?
The
Pardon?
status of the lacrimal sac.
The lacrimal sac
Drainage
was
system.
normal. We have done syringing and other things that was normal
Yeah.
in this.
Because these are involvement of the mucosa.
Yes,
so
yes.
any mucosa other than the conjunctiva, adjacent mucosa is your sinus mucosa. So it's a good idea to even have a look at that also to rule out
Yes.
any involvement.
Yes, yes,
Because if you don't treat the whole thing, there will again be recurrence of the lesion.
What what Dr. Seema is trying to emphasize is basically the mucosa is continuous from conjunctiva to the nasolacrimal duct, and actually it goes down. That is what really happened in COVID also.
Yes.
The whole lining is continuous. So whether the infection is coming from the sinuses or it is coming from outside, that needs to be established, right? So what she was trying to say is that you should also explore whether the infection was limited to the ocular surface or was it, I think that's what you meant.
Yes, ma'am. Thank you.
So anyway, very nice. Thank you so much.
Thank you.